Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Ford, and I'm the chair of Grand Rounds today. And it's very nice to be back on this side of the world. I'm still a little bit jet-lagged, truth be told, but it's nice to be back, mainly because it's actually warmer here than it was in California last week. So I'm top of my tan whilst I'm back here in sunny Dundee. Anyway, welcome to Grand Rounds. It's a pleasure to see so many of you here. It's a pleasure to welcome so many of the haematology department. I hope you'll be coming next week for the next week's talk. Yes, excellent. Good. The haematologists are stalwart attenders at Grand Rounds, always have been, and it's always nice to get the email every couple of months saying, can we have our slot at Grand Rounds? So Katie has asked if she can have a slot on the single unit issue. Last semester, is it Katie? Karen Boyd. Sorry, Karen, if you... Anyway, Karen Boyd presented on an audit that she'd done, or a QIP in the MFE wards about single-unit transfusion, and that has turned into a policy. Yeah, and Katie's here, along with Alan from the Blood Transfusion Service, to tell us all about it. So I'll shut up and sit down and eat my coronation chicken. And Katie Hands from Haematology.
Thank you. Okay, so what I'm here to talk about today is in some ways related to what Karen spoke about before about single unit transfusions, but is more related to the way that we issue blood from the transfusion laboratory. And we're going to make a change to how we issue blood from the transfusion laboratory towards the end of June. So the purpose of us coming here today to talk about it is so that you all know what's happening when that change takes place. And from the 25th of June, what we'll do is, rather than setting aside blood for patients on request, what we will do is issue blood on demand immediately prior to transfusion. So what I'll try and do today is talk through a bit about the processes that happen in the lab, and then a bit more about why we think it's a good idea to change to this process of single unit issue, and tell you a bit about how that will actually happen for you when you have patients that you wish to transfuse. Alan Lowe, the blood bank manager, is here as well to do a bit of the talk. So again, he's going to let you see a bit of what happens inside the transfusion laboratory, which is something that many of you probably haven't seen. So hopefully that will be of interest to you too. So, moving on. So blood transfusion is not without risk, unfortunately. In the UK, adverse events relating to transfusion are reported to SHOT, which is the serious hazards of transfusion. And in 2016, there were more than 3,000 adverse events related to transfusion reported to SHOT. Included in those were 26 deaths related to transfusion. So we use blood most of the time, we use it very, very safely, but when bad things happen, it can be fatal. So it's up to all of us, both at the clinical side, seeing the patients, and in the laboratory, to make sure that we make transfusion as safe as possible for our patients. So if we think about the laboratory's role in this, then what we're trying to do is provide the right blood for the right patient at the right time. And we have processes in place in the lab that I've spoken about here before, like the massive hemorrhage policy, to make sure that we can get blood components to you quickly in an emergency. But what I'm going to talk about today is a bit more about the basics of what we do with a sample when it comes into the lab with requests for tests like a group and antibody screen. So, first of all, a wee bit of revision about blood groups. So, pre-transfusion testing uses serological techniques to determine two basic things. First of all, the blood group of the patient, and secondly, whether there are any red cell antibodies in the patient's plasma. So we inherit our blood group from our parents, and the blood group is determined by the expression of A or B antigen on the surface of our red cells. So if we express A antigen only, we're blood group A, B antigen only, blood group B, both group AB, or neither, group O. And this blood group system was first identified by Landsteiner in the early 1900s. Landsteiner also noted that if an antigen was not detected on the surface on the patient's red cells, the corresponding antibody was present in the plasma. And this is the so-called Landsteiner's law. And these anti-A and anti-B antibodies are capable of inducing intravascular hemolysis of incompatible red cells. So that's why it's so important that we identify the patient's blood group correctly to avoid incompatible blood being transfused and an acute hemolytic transfusion reaction. And this also explains why blood group O is the universal donor, because neither A nor B antigen is expressed, and therefore it's not at risk of hemolysis due to anti-A or B antibodies in a patient's plasma. So our pre-transfusion testing determines the ABO blood group of the patient, but also determines the RHD type. Now, RHD is another red cell antigen which can be present, and it's a very immunogenic antigen. So if an RHD negative patient is exposed to RHD positive blood, they are very likely to mount an antibody response and then have an anti-D antibody for the rest of their life. And that is particularly important if we think about childbearing women of childbearing age, because anti-D antibodies are a major cause of hemolytic disease of the fetus and newborn. So we want to avoid sensitising particularly women of childbearing age by giving them RHD positive blood if they were in fact RHD negative. Okay, so far so simple. But then you become a haematologist, and it turns out that there's a whole load of blood group antigens that nobody ever told you about before. And these are all different families of red cell antigens, which again we inherit, and which again have potential to sensitise patients who do not express that antigen. The exposure to foreign red cell antigens can happen through blood transfusion, or it can happen during pregnancy, where fetal-maternal hemorrhage leads to exposure to foreign red cell antigens that the fetus has inherited from the father. And some of those antibodies, which can be stimulated, will cause clinically significant transfusion reactions. So we need to identify those in the lab so that appropriate blood can be issued for transfusion. And it's important to note that these red cell antibodies won't cause the patient a problem day to day, but it's only when it comes to either transfusion or pregnancy that these need to be taken into account. The presence of antibodies also means that pre-transfusion testing will take a wee bit longer, so we'll come on to the reasons for that shortly. So I thought I'd just take this opportunity to talk a wee bit about the rationale behind some of the rules that exist for both transfusion samples. So as you know, in Ninewells, what we need you to send is a pink top tube, which needs to be handwritten with the patient's details. And those details need to include the first name, the surname, the date of birth, and the CHI. And the reason that that needs to be handwritten is that the British Society for Haematology guidelines about administration of blood components state that in the absence of a bedside computer system, which allows you to print a label on demand at the patient's bedside and affix it to the tube there and then, you have to have a handwritten tube. And at the moment, no such system exists in NHS Tayside, so I'm afraid we're obliged to ask for a handwritten sample. We also operate a zero tolerance approach, a zero tolerance policy, so if we receive a sample which is mislabelled, then that sample will be rejected. So the lab will telephone you and let you know that it's been rejected and the reason why. And this zero tolerance policy is in place because there's evidence that demonstrates if a sample has labelling discrepancies, it is more likely that the blood inside that tube does not come from the patient that is written on the sample tube. Okay? And one study suggests that it's about 40 times more likely. So that's why we reject these samples, because it demonstrates that there's been some carelessness, if you like, at the time of sampling the patient. And we reject about 100 samples a month, give or take, and which represents about 3% of the samples which we receive in the lab. And the majority of those are rejected because of the zero tolerance policy. Sample validity. So there's a box here which you need to tick, saying whether the patient's been transfused or pregnant within the last 3 months. And if that box has been ticked, then the sample will only be valid for 3 days. And that's for the reasons I was talking about earlier. If a patient has been exposed to foreign red cell antigens via transfusion or pregnancy, there's a chance that they will mount an antibody response to that. Now, the reason that it is within the last 3 months is that we know it's unlikely that after 3 months that a new antibody will appear. Most of them show themselves within the first month following transfusion. If no is ticked, then the sample is valid for 7 days. If no box is ticked, then we default to the safest option, which is to have a 3-day validity on the sample. Okay? So that's sample requirements. Then if we come on to the second sample rule, which was introduced in NHS Tayside almost exactly 2 years ago, and the reason that was introduced was it was, again, a BSH guideline, which suggested that unless there was secure electronic patient identification system in place, then we should be performing a group check, so making sure that we have both a historic blood group for the patient and a current blood group, and that those match before we proceed to issue blood. And that, again, is because of the risk of what we call wrong blood in tube, so the blood in the tube not actually being from the patient that it's reported to be. And we know that these happen. In Ninewells so far this year, 3 have been detected, and those are detected because the blood group is different than in the current sample is different than in the historic sample. Okay, it's possible that there are other wrong blood in tube events happening, and we don't detect them because both patients are of the same blood group. Okay, and it's estimated that about 1 in 2,000 transfusion samples are wrong blood in tube events, and we process about 3,000 samples a month, to give you an idea of how many are probably coming through our door at Ninewells. Okay. Nationally, SHOT report that I'm afraid medics are the most common offenders for wrong blood in tube events, and medics taking the samples accounts for more than a third of wrong blood in tube events reported to SHOT. And then midwives are the next biggest culprits. SHOT also report that if these wrong blood in tube events had not been detected, more than 30% of them would have resulted in incompatible blood being transfused to the patient. So it's really important that we're detecting these samples so that we can prevent incompatible blood being transfused. And while what I've said focuses on clinical error, so sampling errors, actually the group check will also detect laboratory errors. So it will, there may be a grouping discrepancy because a previous sample was incorrectly entered into the computer system or something. So it will detect both ends of the problem, but we know that the sampling issues are an ongoing problem. And just to clarify what we mean by a second sample, so this refers to, as I've said, there being a historic sample available on the transfusion computer system, as well as the current valid sample. It's not that you need 2 samples for every single transfusion event that's happening, okay? If you send a sample in and a second sample is required, the lab will phone you and let you know, and there will be a message on ICE to let you know that a second sample is required before blood can be issued. So that's all there for you as well. Okay, so if we think about antibody screening, so how do we actually go about detecting whether the patient has any antibodies in their plasma? Well, what we do is we use what are called reagent red cells, so those are bought in, and these red cells express a known selection of red cell antigens. We then mix those with the patient's plasma and perform an indirect antiglobulin test, looking for evidence of the presence of antibodies. And what we actually do for the routine group and screen samples is what's called a 3-cell screen, where there are 3 different reagent red cells which will all express a different combination of red cell antigens, and the patient plasma is tested against each of those. And those 3 different cells will express all of the major antigens to which patients may form clinically significant antibodies. So if we do this test and we don't detect any antibodies, you'll get the report on ICE that looks like this, where it says automated antibody screen negative. And as I say, that means that we've not detected any antibodies which are likely to cause a transfusion reaction. So if the antibody screen's negative, at that point testing is complete. However, if in the antibody screen we identify the presence of an antibody, we'll then perform further testing against a panel of reagent red cells to allow us to identify exactly what that antibody or antibodies are. Okay? And this then allows us to select appropriate units for transfusion. So sometimes we may need to select antigen negative units, for example, so this process allows us to do that. Now, about a quarter of the blood in Ninewells is issued following serological cross-match. So that's actually mixing patient plasma with donor red cells in the lab and checking for any evidence of incompatibility. Again, we use the indirect antiglobulin test to do that, and we need to do this if an antibody's been detected and if various other criteria are met. The laboratory will put the sample through serological cross-matching. But about 3/4 of the blood in Ninewells is actually issued by electronic issue, and this is coming on to the bit about this new process called single unit issue and how it will actually work. So essentially, if we're happy that our automated testing has determined the blood group and a negative antibody screen, we've excluded any clinically significant red cell antibodies. Then what we can do is use the computer to select an appropriate unit for transfusion. Okay, so basically a unit which is ABO and D compatible will be selected and issued by the computer to the patient without any formal serological testing, so no actual mixing of patient and donor samples. Now, the safety of this process relies on all stages of the process being robust, so right from sample registration, where samples will be discarded if they are labelled incorrectly, all the way through the analysers being subject to the appropriate quality control, through to making sure that the computer system is set up in such a way that the results are transmitted electronically from the analyser to the laboratory computer system, and things like using barcode readers to identify samples rather than any manual steps, because we know that the more manual processes that are involved, the more chance there is of risk. The current sample must also be subject to various criteria before electronic issue can proceed, including if there's a positive antibody screen, if the patient's known to have had a stem cell transplant. And the computer needs to be set up in such a way that it decides who is suitable for electronic issue and indeed who isn't. So it's not down to any of the lab staff to decide whether electronic issue can proceed. It's the way the computer is set up which does that. But what electronic issue does is it allows us to issue blood really quickly. So it takes about 5 minutes to electronically issue blood to a patient after the initial pre-transfusion testing has been performed. And it also allows us to issue blood remotely. So transfusion support for patients at Stracathro involves a remote issue fridge, which basically performs electronic issue linked to our transfusion lab system at a distance up the road in Stracathro. And in some other hospitals, they have remote issue fridges actually within the hospital. So, for example, the Queen Elizabeth in Glasgow has a remote issue fridge outside its theatre and a remote issue fridge at its emergency department. So blood can be issued electronically in those locations. So it's these patients who are eligible for electronic issue that we propose changing to this single unit issue process. So why do we want to do this? Well, most of it, or some of it, is because we have been asked to improve our cross-match to transfuse ratio. So our cross-match to transfuse ratio basically determines for every unit of blood which is cross-matched, how many go on to be transfused. And in Ninewells, we're the yellow line, not going to name the other hospitals. Ours is consistently between 1.6 and 1.8. So for every unit of blood that's transfused, we've actually set aside about 1.8 units. So when that blood's set aside in the issue fridge, it's not available for anyone else, means that we have to keep a bigger blood stock, means that stock gets recycled almost through the issue fridge on a regular basis. And what would be much better would be if we were issuing blood to a patient and we knew that it was then going to be transfused. It leads to better stock management. Now, lots of things feed into your CT ratio. Things like the MSBOS, so the maximum surgical blood ordering schedule, which suggests how much blood to cross-match before a given procedure. If you've got your MSBOS wrong, it'll be instructing people to cross-match lots of blood where it's not required. Confidence in the transfusion laboratory feeds into it as well, because if you as a clinician are concerned that the transfusion lab aren't going to produce the blood you want when you want it, you're going to try and get them to produce it ahead of schedule so that you know it's sitting there. So hopefully if we can increase confidence in our service, that will make you happier that we can continue with this single unit issue process. And what we would like is to be down here with these other hospitals, and these other hospitals have already implemented single unit issue, and that's what has helped them to drop their CT ratios down. Okay, so it works well in these other hospitals, and I don't think there's a reason why it ought not work here. From a clinical point of view, as Tom mentioned, we've previously spoken here about single unit transfusion, and increasingly clinical guidance is to use blood as a single unit rather than perhaps what you've been used to of using 2 as a dose, so using a single unit and then assessing response. So I think this process of us issuing only a single unit will kind of facilitate that process where if you're needing to make a second call to get hold of a second unit of blood, perhaps you'll reassess the patient in between. So I think it has clinical benefits as well as the benefits to things like blood stock management. So what will this look like? Well, at the moment, this is the sort of flow, if you like, from a sample coming into the lab with a request for blood. The pre-transfusion testing will be performed and then units will be issued to the patient. And those units will be put into the blood issue fridge, which sits down outside blood bank, and it will be held there for 24 hours. And those units may be transfused, but as I've said, about half of them are not transfused and they're returned to stock. And at the moment, we have about 20 or 30 units sitting in the issue fridge at any one time. So under the new approach with single unit issue, the sample would arrive. So for patients without any immediate transfusion requirement, the sample would arrive. The pre-transfusion testing would be done. Once a patient's been determined to be suitable for electronic issue, at that point we would not proceed any further, so no units of blood would be issued. What we would then like you to do is when you've decided that you actually want to transfuse your patient, you give us a ring at blood bank and we will issue a single unit of blood to the patient and put it in the issue fridge within 15 minutes of your call. You then can transfuse the blood, assess your patient. If further transfusion is required, then a further call to blood bank for a second unit, and so on. For patients who are not suitable for electronic release or electronic issue, at this point, units would be prepared as normal and put into the issue fridge. And when you phone to say you're ready to transfuse your patient, you would be told that the blood was ready in the issue fridge for you. It's important to note that there will be no change to how blood's provided in an emergency. So if you have a bleeding patient, you phone blood bank and ask for units of blood, there will not be a restriction to single unit issue for those patients, nor will there be any change to things that are already in place like the massive hemorrhage policy and the code red policy. And if there's a particular patient who you're concerned about, so you're going to take a patient to theatre and you think there's a particularly high chance of bleeding, then of course we'll set units aside for them as we have done at the moment. But I think for most patients, including most elective surgical patients, the new process of single unit issue on demand will be suitable. So we'll review this after implementation a week, a month and 3 months. And obviously, if there's significant issues, then we can return to the old process and nothing has been lost. I should also mention that we've got a well-established contingency in place because obviously this is very reliant on computers. But as I said, about 3/4 of the blood issued in Ninewells at the moment is issued via electronic issue. So we have a well-established contingency in place for if the IT systems go down. Okay. So, now I'll hand over to Alan, who's going to talk a bit about the laboratory side of things. Go.
So I'm going to get just a real summary of the testing that we do in the lab, the processes that we do in the lab, and the changes that we've made for single unit issue. Just a little bit of information on the staffing of the lab. We currently have around 14 biomedical scientists and 8 support workers, but they're not there that's to cover our shifts for 24/7. So we don't have that amount of staff on any given day. After 5 p.m, we reduced to having 2 biomedical scientists and 1 support worker. So hopefully the workload drops a little bit after 5 o'clock and we can cope with that. And then after 10 p.m. at nights and at weekends, we only have 1 biomedical scientist in the department. So I'll just give you an idea of the staffing that we have. This is the outline of the procedure. So really we take it from receiving the sample through all our testing till eventually we come to issuing the blood. So I'll just go through each step really. When we receive the sample in the lab, as Katie mentioned about the importance of correct labelling, we will actually review the sample labelling and check that it's all labelled correctly, that we have all the points of ID that we need. We then enter the details into the lab's computer system. And at that point we can check the previous history and we can ensure that the details match the previous records that we have. And that then gives a unique sample barcode that we apply to the sample, and that number then follows that sample through the process from there on. At that point, we'd also see from the computer system any previous history of that patient, so we can see their previous group, if they have antibodies, or if they need any special components such as CMV negative. We'll then start testing the sample. So every sample will get the A, B, O and D group and an antibody screen. And as we mentioned, it's important that it's done using automated equipment, and we'll do that wherever possible. When I started, we still used to do the testing in test tubes, but we've moved on to this technology now, so the rack of samples into the analyzer. The other important fact is that the results are transferred automatically as well. There's no manual entry of results into the system. It's transferred directly from the analyzer into the lab computer system. And that's just to let you see the actual technology that we use for grouping. So the top is the front and reverse of an ABOD card. That patient's ARH positive, I believe. And you see on the reverse of the card, each card itself has a unique barcode, so that's linked. The analyzer would read the sample barcode and would link it to the test barcode, so that keeps that security all the way through. And then the bottom one is an antibody screen. There's actually two on there. It's a 3-cell screen, so we get 2 per card. So after initial testing, this is the final step, and it's at this point that we actually check all the results that come from the analyzer. So at this point, we actually check that because we enter the details manually into the LIMS system, we'll actually check that whoever has registered the sample has done that correctly, and we haven't made an error. And we'll also at that point compare with the current group with the historic group. If we find a discrepancy at that point, obviously we can't continue any further. In fact, the system won't allow us to do anything more with that sample. We can't issue red cells or complete the testing or issue a report from that sample. Also at that point, we'd find if, in the case of a patient with an antibody, it would highlight that we need to do further tests. If the patient was then, when we review all this information, if the patient's suitable for electronic issue, we'll note that as well. So this procedure, end to end, is really the group and screen part. So when you ask for a group and screen, that's as far as we go. And that would take, I've said 45 minutes, probably maybe 40 minutes as a minimum. That's taking one sample, if you dealt with that sample, from end to end to the exclusion of others. So that's the kind of minimum time that it would take. If there's a red cell request, we'd actually select red cells for the patient. I say appropriate ABO group, we normally try and give the same ABO RHD group as the patient, but to achieve best use of blood, or sometimes if the patient has antibodies and we need to select for other blood group systems, we may have to select an alternative compatible group, ABO group. If the patient has antibodies, say we may have to look at other blood group systems, and that may it'll increase the amount of time it takes, but we also, in some cases, need to order blood from supplies in Edinburgh. We may not have that particular group in stock. And we also have to take account of any special requirements. In the cases where we need to do a serological cross-match, so when patients are unsuitable for electronic release, we actually have to do a serological cross-match. You can see the pigtails on the pack, the little segments, that's where we take the sample from for testing the donor cells against the patient plasma. And that end-to-end, to do the testing and issue, is about another 45 minutes. However, when the patient's suitable for electronic cross-match, the computer cross-match does all these checks for us. So it checks that the current group is identical to the historic group. It also knows that it's an automated result. There's a different system from an automated result from a manual result, and there also has to be an automated transfer. So once we have compatible units that we're happy are compatible with the patient, we actually go to issue. And this is really the part where we give it the familiar label, the blue and pink label there with the patient details. So that's the computer check of compatibility. And if it's suitable for electronic issue, the system will allow us to issue the red cells. If it needs a serological cross-match, we can't proceed until we've put that result in, a compatible result for that electronic cross-match. So there really is an electronic control of the system. And you can see the blood there. So the changes with single unit issue, we would complete the pre-transfusion testing to the end of the process, so we get as far as verifying the results. And at that point, if red cells have been requested, we wouldn't issue any red cells. And then when the ward or the clinical area requests the blood, hopefully 50 minutes before they need the blood, then we'll just issue the unit and it'll be placed in the fridge. So I have a video here of the process, just to kind of give you reassurance of how quickly we can issue the blood when you phone and ask. So we think it takes about 5 minutes, but I'd say we allow 50 minutes because, especially in times where there's only one person in the lab, there may be other tasks that they have to perform. So at this point, you'll be asked the usual questions. So we'll ask for the first name, the last name, the date of birth, CHI, probably. And we record all the calls on a log. So if there's any queries later on, if blood hasn't been issued, we can find out why. And that's why we always ask for your name as well. That gets recorded on that sheet. And this is the point you'll hear us saying, hang on a minute, I'll just check the computer, I'll check traceline. So we'll go into the system, look up the patient, and we'll just ensure that they've got a valid sample. Hopefully we do. Sometimes it's especially when it's over 3 days, sometimes we can see the patient history there, the group, and we'll have a request there. And we can see the sample validity time as well when the sample expires. So we keep the request, so we'll go back to the original request form. And we'll double check the group before we select red cells. And this is the actual electronic issue, so that behind the scenes the computer will be making sure that all these criteria are met and that the blood is compatible with the patient. And we like to check our identity, so you'll see that we check everything again, check that the label matches the request form. And this step here, this verifies that we've attached the right label to the right bag. So we get a printout. The first printout is just for us to say which units have been issued, and then the second one, which always takes a wee while, is the fridge register that you've maybe filled in, the one that lets us know when it's going in and out of the fridge.
The slowest bit of the whole process.
Yes. Up there it goes. And then again, we check it all again, just on the off chance that we've printed 2 fridge registers at once from another terminal and we haven't mixed them up, so we just make sure everything matches. That's just a timestamp that lets us know when it's gone into the fridge, so we can keep the cold chain. We know where and when it's been stored. A bit of advertising. Okay. So that's the system. So hope it lets you see that it literally just takes 5 minutes for us to issue, and it gives you reassurance that when we go to single unit issue, you'll be able to get you'll get the blood in plenty of time.
Yep.
I think that's all.
Okay. Any questions? Thank you.
Right, this is going, sorry. Okay then, so questions, comments? Whilst I power this up. So what's the story with non-red cell blood products then?
So
I understand we give plasma occasionally.
It's true. So plasma is thawed when you need it, which takes...
I'm listening, carry on.
It takes about 45 minutes to thaw, although at the moment we're working on reducing that thaw time. And we're also working on having pre-thawed plasma available in the emergency department so that when trauma patients come in, it's available for them more quickly, because there is always a bit of a delay. For platelets, we hold a stock of 2 units of platelets, so there ought to always be one available if one is needed in a hurry. But equally, if there's a sort of elective need for platelets, so before a procedure, then we can order them up in advance.
Okay, good. Oh, question at the back. I got Julia.
Thank you. Hi. What are the rules with the second sample for a first-time transfusion? There was some confusion when I was waking up in Arbroath as to timing between samples and who's to take them.
It should be 2 separate sampling events, not 2 samples taken at the same time. Otherwise, it kind of defeats the purpose.
But it doesn't have to be any specific amount of time between the 2, just as long as they're taken at separate times.
Yes, yeah.
What did the Green Hospital do? They had a really good drop-off in 2000 and something or other. You're not going to tell me which hospital it was because you're too...
I probably don't even know off the top of my head which one it is, but probably single unit issue. The other thing which big hospitals which have a lot of surgery often have reviewed their MSBOS, so their maximum surgical blood ordering schedule. So if you have been saying forever to cross-match everyone that's having their hip done for 4 units and you suddenly say that people having their hip done don't need any units cross-matched, then that'll have a good big effect. So things like that can play into it.
So it's all the fault of the orthopaedic surgeons. I've long suspected as much. Okay, anybody else got any comments or questions they'd like to throw at the haematologists? No? Okay, well that's it then. You're off the hook.
Thank you.
Something I should throw at you then. I was emailed by somebody from the blood transfusion service just about an hour ago. There is asking me to take part in an appeal for blood donors, which is going to be on the 11th of June. Which they're asking people to drop the A's, B's, and O's from Facebook pages and things. So you know that I help run Parkrun. So for 1 week only, it'll be Parkrun to try to support to get people to acknowledge to go and donate their A, B, and O blood. So if you are a blood donor, then thank you very much and carry on giving. If you're not a blood donor, then think, why are you not a blood donor, and could you go and donate some blood, because there is a shortage of all blood groups, despite our best efforts. So that's a quick plug for that. Next week at Grand Rounds, Fiona Cameron, who's Associate Postgraduate Dean for Foundation Training, is going to come and talk about foundation training, and with particular reference, I think, to the hurdle that exists at the moment between Foundation Year 2 and then Specialist Training Year 1. At the moment, only about 40 to 45% of our FY2 colleagues take on ST1 training posts, and we don't really know why. And we need to try and do something about that, because there's a real shortfall in our workforce. So if you're interested in training, if you're interested in where all your trainees have disappeared off to, then come and see Fiona Cameron next week. Okay, thanks again to the haematologists, and I'll see you all next week.